Welcome to the Confident Smile Podcast, where we talk with the leading experts on how to treat dental issues and get healthy gums and a beautiful smile. With your host, Dr. William Levine, a periodontist of 35 years and chief scientist at Periactive, a trailblazer in oral care. Periactive is clinically proven to reduce inflammation and promote gum healing within 60 days.
Today, we're honored and pleased to host Dr. Howard Tenebaum, or Professor Howard Tenebaum. Dr. Tenenbaum is a professor of periodontology at the University of Toronto for many, many years at this point, and was head of the Department of Periodontology at that university. In addition, he has an appointment to the Department of Laboratory Medicine and Pathophysiology, not only in the Faculty of Dentistry, but also in the Faculty of Medicine at the same university. More important than that, Dr. Tenenbaum was actually listed as one of the top 2% of leading scientists in the world. So we're honored and pleased to have Dr. Tenenbaum here. And our topic for today will be a healthy body and a healthy smile. So Dr. Tenenbaum, perhaps let's start off with that opening statement, a healthy body and a healthy smile. We've heard a lot in the literature about the interaction of the health of the body and in fact affecting the health of the mouth, and conversely, about the health of the mouth affecting the health of the body. Perhaps shed a little light on that general topic, then we'll plunge into further details.
Okay, well, first, thanks for having me on this podcast. It's a pleasure. Before we talk about the health of the mouth and health of the body, one of the things that I always like to raise when I enter these discussions is the notion that we tend to forget that when we get all excited about oral health and systemic health, that the establishment of health in the mouth itself, oral health in the mouth itself, is in of itself an important goal. Why? Well, I mean, if you have unhealthy teeth, you're subject to pain, infection, possibly acute infection requiring even hospitalization. If you lose teeth, your ability to eat is reduced to the point where you may even have digestive problems. Less than 20 teeth, you begin to have digestive problems. And of course, there's the social aspect of missing teeth as well, which can impact your ability to get a job or interact with other people. So I want to set that sort of baseline right at the outset, saying that the establishment of oral health in and of itself, irrespective of its relationship to general health, is extremely important. Now, having said that, though, it turns out, of course, that we've been studying this for years now, and it's become quite clear that the establishment of oral disease may have a negative impact on non-oral disease conditions. And in particular, we look at two major aspects of oral diseases. One is infection with various disease-causing bacteria that can cause dental decay, which is bad. Those sorts of infections may or may not have an effect on general health. We don't know yet. But what seems to be quite clear in terms of correlations, and I would say even causation, is the association between infection of the mouth with certain disease-causing bacteria and the development of inflammation in the gum tissues, gingival tissues in the mouth, leading to what we call gingivitis or periodontitis, which can lead to tooth loss and so on and pain, but also seems to set the stage for a strong correlation between other non-oral diseases. And so the presence of periodontal diseases, gum inflammation seems to be associated with risks for non-oral diseases like diabetes, for example, and also seems to be associated with poor outcomes for treatment of these diseases. And we can get into some other aspects of that as well, which relate to the notion of bidirectionality.
So maybe share with the audience of what type of diseases systemically do you think would be impacted or potentially impacted by the presence of a inflammation or infection in the mouth?
So the most common one, and the one that really popped up the earliest, is diabetes, diabetes type 2, not so much diabetes type 1. And individuals who have severe gum disease or moderately severe gum disease are at more risk for the development of diabetes type 2. They're also at more risk for being pre-diabetic. And similarly, I think it's quite clear that people with uncontrolled or poorly controlled diabetes have more severe gum disease, but we can get to that afterwards. Other conditions that have been associated statistically and rather strongly range from dementia, believe it or not, to cerebrovascular disease, strokes, cardiovascular disease, hypertension, and there are even some studies where the standard blood pressure measurements don't necessarily show something, but they do see that there is a disease process ongoing in the blood vessels, which leads to the development of symptomatic hypertension. So hypertension, heart disease, and we now know that the presence of severe periodontal disease is another risk factor, for example, for the development of severe respiratory diseases such as influenza and even COVID. That's been shown. We weren't actually surprised to see that there is a correlation between the presence of the presence of periodontal disease and increased risk for the development of severe COVID that might require hospitalization, for example, possibly even ICU.
Just to sort of clarify that point, people who have, for example, advanced or acute periodontal inflammation and get exposed or get infected with the COVID virus, would you expect their disease to be more severe, or is that how you would express the sentiment or the
That's
literature?
actually how I would express it. There's an interesting anecdote of when COVID first hit the scene in the Toronto area. An individual who was said to be completely healthy, they couldn't understand that he was an older man, but he died from COVID. He was hospitalized, and his physician and children just couldn't understand. And I recall it just struck me seeing a photograph of him when he was still alive with his kids, smiling, with half of his teeth missing, and severe gum disease and recession on the rest of his teeth, which nobody else, physicians, let's say, noticed. And right away we said, well, yeah, this is a cofactor. Just like they said, there are other conditions that were cofactors, such as diabetes, for example, which is a risk for severe COVID outcomes. So it turns out so is periodontal disease, gum disease.
Fascinating. So it's actually something, taking care of your gums and taking care of your teeth really have an impact on your overall health. Is there any thought in terms of what is the mechanism of action, or how the body, the inflammation in the mouth, would affect such a broad range of different diseases?
Yes, sure. Well, there's plenty of possible mechanisms, and I would say several of them are good contenders, but the profession, the research groups still don't really have a complete handle on this, but we're getting a better picture as time goes on. And two things have come up that I think are worth considering. One, if you have gum disease, because you have not been cleaning your teeth in all likelihood, and your teeth are coated with all sorts of bacteria, including bacteria that are really primed to cause severe inflammatory gum disease and dental decay for that matter. When you brush your teeth, if you brush your teeth or even eat an apple, these bugs, these bacteria can get into the bloodstream. And this is called a bacteremia. And it's thought by some that this explains the linkages between periodontal inflammation and systemic disease. Why? Because you've got these disease-causing bacteria getting into the mouth, getting into the bloodstream from the mouth. When it comes to, for example, Alzheimer's and dementia, there are some good studies showing that bacteria that are known to cause gum disease are also found in the brains of patients with Alzheimer's and with severe dementia, and that they produce what we would call virulence factors or toxins that may actually lead to the dementia itself. So that's a possibility. And in fact, there's a big research push to try to figure out how to eliminate these periodontal disease-causing bugs from either the brain, or at least to block their ability to produce these toxins that may lead to dementia. So that's one area. And in fact, I would say we are probably looking at a combination of factors. So the secondary, which I think is actually more profound, but I think both should be seen as co-conspirators, and that is the sort of generalized upregulation or uptick in inflammation. You become almost like an inflamed canvas, so to speak, which allows for other inflammatory diseases to take hold and to become more severe. What do I mean by that? It's sort of like throwing gasoline on a fire. You have to consider that diabetes, we'll use that as an example, or atherosclerosis, hardening of the arteries, heart disease. These are actually inflammatory diseases. Many years ago, people didn't really think that atherosclerosis was an inflammatory disease, but it is. And so here you've got these inflammatory diseases. Think of them as little fires. Think of them as low as perhaps embers, burning embers throughout your body, and you happen to be diabetic. And then the next thing you do is you develop gum disease. And you develop gum disease, and the cells within the gums and even distant from the gums that are responsible for controlling inflammation actually become quite stimulated, and they enter the bloodstream either from the gums, and in some cases it's been shown that these cells might even start to develop early in the marrow, and it's like throwing gasoline on a fire. They're circulating in the body, and if you happen to have another inflammatory disease, that inflammatory disease can be affected by those other inflammatory factors. They can be proteins, they can be cells, which stimulate inflammation. If diabetes is an inflammatory disease, and you start throwing in cells from the diseased mouth that have gotten into the bloodstream and are themselves pro-inflammatory, they stimulate inflammation, then they could just as easily stimulate the inflammatory process that's occurring in diabetes. And so we see that the presence of this inflammatory disease will set the stage for and exacerbate, make worse, already existing inflammatory diseases. And the diseases that I mentioned previously, they are inflammatory in nature, these systemic diseases. I won't bother repeating them. So what I would say is it's probably a combination of the mouth disease or the oral disease, which is producing pro-inflammatory factors that get into the bloodstream and can stimulate distant inflammatory diseases. Even cancer, by the way, there is an inflammatory trigger, and that's been shown recently to be correlated in a study done by a group led by Harvey Risch. And we also have the bacteria, and I think they work in concert, but the bacteria are not always in the bloodstream. Maybe it's incidental, but I wouldn't rule out that the oral pathogenic or disease-causing bacteria, together with the release of these inflammatory cells and inflammatory proteins, combine to make worse and or set the stage for the development of other distant inflammatory diseases. So it's not just a correlation. It's not just that we find them both. A lot of people thought it was just a correlation. In other words, if you have a bad lifestyle, you don't brush your teeth, you probably have a lot of sugar in your diet and you get diabetes. No, it's not just a correlation. There seems to be this mechanistic link, which is related to the background upregulation of inflammation.
Well, that's actually a pretty revolutionary statement that I think is really cutting edge in the way people are thinking. But what you're saying is that basically that periodontal disease can be among the causative factors for a lot of these major diseases. Well, maybe not the sole causative factor, but certainly one of a significant causative factor.
Correct.
So, but would it be correct for me to say that let's say treating the disease may impact on periodontal disease or your inflammation or the health of your mouth, and conversely, treating your mouth would impact potentially on the disease that you're suffering from? So, for example, if a person has a cardiac system or cardiac situation, a history of heart attack or myocardial infarct, and the doctor doesn't even mention periodontal disease as a risk factor, then I think the doctor has not given the patient the full picture of how important his dental health is to his overall health. So I'd love you to comment on the bidirectionality of the potential treatment of each, as well as the fact that the medical world doesn't really see periodontal disease yet as something important. Like, for example, the doctor will tell him to lose weight, and the doctor will tell him to exercise, but he won't tell him to take care of his teeth.
Right. I can tell you that physicians receive very little education in dentistry and dental related problems. We've worked with people in the cancer treatment area, people who should be concerned about the severe ulcerations that occur in the mouth. When they assess these patients, they almost look past the mouth down the throat. They miss everything in the mouth. And we actually saw this in a study that we did. We developed a way to assess oral mucositis that occurs in cancer treatment. So they don't see it. And I think the bidirectionality is going to prove to be extremely important and perhaps a little harder to prove for several reasons. One might be that if a disease progresses really slowly, how do you design a clinical trial to assess the impact of treatment of one disease on the other if one or both of the diseases progress slowly? So it's going to take a while to prove this. However, I would say that we do have a good model to prove this, and one which is, I think, emblematic of what's probably going on in other systems. So let me get back to the heart disease that you talked about. I don't think there's any question that periodontal disease is a risk factor for the development and perhaps exacerbation of heart disease, heart-related disease. In fact, a research program carried out by one of my colleagues, Mike Logauer, showed that they see a panel of inflammatory cells in periodontal disease patients that you only see in patients who have heart disease or rheumatoid arthritis. So there's definitely a biological link there. However, what we don't know, and what nobody has shown yet, really, at least to my satisfaction, is that treatment of gum disease will definitely reduce your risk for heart disease. It's just too slowly progressing a condition to really show that you have a significant reduction in, let's say, infarct or heart attack. I mean, how long does a study like that have to be? And ethically, how do you have a control group and let them wander around with gum disease untreated? So it becomes a really difficult thing to solve. But what has been easier to solve, I would say, is diabetes. I think there we have probably the best model system to show this bidirectionality, because you can look at surrogate markers for disease which do predict disease progression and play a role, in fact, in disease progression. We all hear about A1C. Hemoglobin A1C not only is a marker for diabetes, but it plays a role in diabetes as well. It's an actual inflammatory pathogenic molecule. And I think here we have good evidence of bidirectionality. And what I mean by that is, if you have diabetes, or you have a patient with diabetes and the doctor is having trouble controlling it, or the patient's having trouble controlling it, and you happen to see that they have severe periodontal disease, if you treat that periodontal disease, it's more likely that the doctor will be able to control the patient's diabetes. In other words, treatment of the periodontal disease will lead to improved disease parameters in diabetes. And it goes the other way as well. We know, for example, that if we see patients who have severe gum disease that we're having trouble controlling, and it turns out that they have uncontrolled or poorly managed diabetes, that if the diabetes treatment can be perhaps brought up to a much more strict level and applied more strictly, and the patient's diabetes is brought under more control, that you see concurrently our ability to treat that patient's periodontal disease improves. And that, to me, is one of the best models for bidirectionality. Now, you'll have people who argue with that, but I ask you, why is it that they only argue with the fact that infection in the mouth can make diabetes worse, but have no problems when they say, oh, but if you have a toe infection, if you have a bladder infection, if you have a big ulcer on your foot or your arm, you'll see diabetes control go out the window. That they believe, but somehow they're resistant in terms of saying that the same thing happens in the mouth. Well, it's the same mechanism, and we're dealing with similar disease processes: inflammation, ulceration, bacterial invasion, and so on. And then these all conspire to make the diabetes worse. And the diabetes, which is an inflammatory disease, and essentially turns the patient also into this inflammatory canvas, as I said. And so their gum disease could be worse too. There, I think we have the best model. And I would go further then to say that even if we haven't demonstrated bidirectionality, or even if we have not uncovered all the mechanisms of potential causality, or all the potential mechanisms of causality between oral disease like periodontitis and the other diseases I was talking about, like hypertension, heart disease, dementia, respiratory diseases, and so on, and even cancer, even if we have not done that, why would we not expect that to occur, since it's so well demonstrated in the area of diabetes and periodontal disease?
It's really fascinating because it just stresses for us how critical it is, your oral health, not only to maintain its primary cause of your mouth in its healthy state and functionality, but equally important to maintain the overall health of your body. So let's still take a patient who does have some type of systemic disease. Is there any suggestions that you would make? I mean, you've described this as an infection and an inflammation. And is there any, let's say, suggestions that you would make in terms of their overall healthcare that may be supplemental or different from the normal healthcare that people are using on a daily basis?
Yeah, absolutely. I think one of the biggest sort of disconnects or holes in the overall healthcare is something that I think we alluded to at the beginning too, and that is that if you have a patient who comes into your office, you're a physician, and they have diabetes, you need to either use some sort of diagnostic test or send them to their dentist or hygienist to assess their mouth for the presence of periodontal disease, because we know that the probability is increased that they're going to have periodontal disease. And if it's uncontrolled, that would help explain why this patient's condition might be more difficult to control, or at the very least, you need to rule out the presence of oral disease. So they need to have this assessed. And if present, it can be mild, moderate, severe. Various types of treatment interventions need to be invoked, or at the very least, if they don't have severe disease or don't have any disease yet, but they still have diabetes, you need to institute a good home care regime to prevent the development of oral inflammatory disease, for example. And that would include simple things like getting them to carry out good oral hygiene at home, like brushing, flossing, and then there are antibacterial rinses. And in particular, there's a rinse that we have been using when I was at Mount Sinai Hospital, which I hope I can mention now, called Periactive rinse, which is an anti-inflammatory rinse, which is fascinating. Its clinical effects on periodontal inflammation are remarkable, to the point where patients actually notice the difference. And let me tell you, when patients notice a difference in how their gums feel and actually realize that they feel better, that's remarkable, because most people are completely unaware of the fact that they have gum inflammation or gum disease. They don't feel it, but boy, when it goes away, they feel better. It's a really interesting story. And we saw a lot of this when we started to introduce this periactive rinse. Now, what's interesting with the periactive rinse, at least for me from a scientific perspective, is that you think, oh, it must kill bacteria. Well, it may kill bacteria, and we'll get to that, but its most profound effects appear to be that it is an anti-inflammatory rinse. And because of its anti-inflammatory effects, I think that this is why we see such profound improvements in the oral health of these patients. What's interesting in these patients is that if you look for disease-causing bacteria in their mouth, those go down when they rinse with the periactive rinse. So you think, oh, it's also killing bacteria. But if you just take periactive and test it in a test tube, it really doesn't seem to have as profound a bacteria-killing effect as you might have anticipated. This led me to conclude that the presence of inflammation in and around the gum tissues actually sets if you will, the stage for a hospitable environment where disease-causing bacteria thrive. And so the disease-causing bacteria, and I won't bother identifying them, I guess, in this particular discussion, but there are a number of disease-causing bacteria. And when these see that they have this inflammatory environment in which to live, it's very hospitable for them. And so they take hold and they proliferate. And then you start getting even more inflammation and probably the buildup of even more numbers and or more different types of inflammation-inducing bacteria. So what do? Well, we get the patient to floss, we get them to brush, but we know patients don't floss and brush all that well. They do their best. You put them on this anti-inflammatory rinse, and you start to see clinical improvements. And you also see that these bacteria are disappearing, these disease-causing bacteria. But you just showed in the test tube that it's not really killing the bacteria. So what I believe is happening is that it's reducing the overall inflammatory environment. It's reducing inflammation. That environment becomes less and less hospitable to disease-causing bacteria, and the more health-associated bacteria begin to take over. And I think you have a sort of two-pronged effect of something like Periactive then. Number one, it's anti-inflammatory. So even if the bacteria were still there, if it's blocking inflammation, who cares? Well, maybe I'm being a little bit cavalier. But if you block the inflammation or reduce the inflammation, you get the added benefit of creating a non-hospitable environment. And these disease-causing bacteria have nowhere to go, they can't thrive, and they begin to disappear.
Just to probe that point a little further, you recommend Periactive for all patients who have potential systemic implications or risk factors or other diseases. But what about patients on a daily basis? Do you use Periactive as a preventive, even if they don't have a systemic disease?
You know, if somebody's mouth is completely clean and they have absolutely no evidence for gum disease, inflammation anywhere, whatever they're doing is fine, to be quite perfectly frank about it. However, if they develop even the mildest of signs of inflammation, meaning their home care is not great, you know now that you have a patient who is at risk for developing increasingly severe gum disease. Why not help them out? And that type of patient, that sort of middle patient, not the one who's completely healthy. I mean, you don't treat somebody who's completely healthy and they don't need to do all sorts of preventive therapies for something they don't have. But if they do start to present with some degree of inflammation, and this is where actually it becomes almost universal in the sense that lots of patients, maybe 90% have some degree of inflammation, and certainly 80, 70% have enough inflammation that it would make me, even as a general practitioner, say, this is part of your home care regime: brushing, flossing, Periactive rinse. So it would be used probably in the majority of patients presenting to a dental clinic. But there's no reason to utilize interventional therapy of any sort if the patient is completely healthy. Why would you do that?
So first of all, Dr. Tenebaum, Professor Tenebaum, thank you very much. We very much appreciated your time, your insights, and really you shared with us a lot of important information about how to keep a healthy body by keeping a healthy mouth, and how to improve your oral health by keeping a healthy body. And I think it was very helpful, and thank you, and I hope our listeners enjoyed it. So I'd like to thank you all for tuning in to the Confident Smile podcast, and we look forward to hosting you again with some other interesting topics.
Thank you for tuning in to another enlightening episode of the Confident Smile podcast. Remember, your smile is your greatest asset, and taking care of your dental health is key to showcasing it with confidence. Stay tuned for more valuable insights, tips, and expert advice to help you achieve and maintain a healthy and beautiful smile. Until next time, keep smiling with confidence.